Okay, let's begin our session with Kitab Al-Fatih. Okay, all right. So, who's presenting?
It's me, Kizandra Mesara.
Okay, all right. Okay, proceed. Let's begin.
Okay. My patient Dini, a 2-year 9 months old girl, was referred from a GP to HKA in view of vomiting for 1 day and lethargic for 5 weeks prior to admission. Next. Okay. 1 day prior to admission, the patient suddenly vomited after taking meals. It was a non-projectile vomiting. The vomiters contained undigested food and liquid. There was no bolus or blood. It occurs for about 4 times and each episode contained about 3/4 of a cup. Other than that, there was no irritability, dizziness, and seizure. There was no history of head trauma and any same presentation within the family or the nursery. Due to this symptom, the patient was brought to a GP. At the same time, the caretaker also consulted the attending doctor regarding the pallor of the patient. Blood investigation was done that time and revealed severely low hemoglobin level, which is 4.4. Thus, this patient was referred to HTA. Upon further questioning, the patient had pallor since 5 weeks ago. It was first noticed at the feet of the patient by the patient's mother. By the way, this patient is brought to the GP by the caretaker. Then, basically all this history is from the caretaker. Then, followed by her palms of hands and lips, the pallor followed by her palms of hands and lips. She also noticed the child become less active than usual. Usually the patient will play with others and talk frequently. However, since the pallor, she only observed other people play from the side and top left. Furthermore, they also noticed of easy bruising, especially at both lower extremities 3 weeks before she arrived at the hospital. There was a history of fall during that time, resulting in lip laceration, which resolved spontaneously without increase in bleeding time. There was also no joint swelling. She was unsure of recurrent infection. However, this is the first time the child was being admitted. In addition, she had a history of infection that fully resolved after seeking treatment at GP 2 weeks before the current admission. The history, the caretaker was unsure of bone pain, but the patient reported to have trouble of sleeping at night due to generalized body pain. The patient had a habit of eating sand. It was witnessed by her mother, and there was also sand noted at the patient's diaper. The caretaker was unsure since when the symptom occurred. The latest event was on the day of admission before she was brought to GP when she licked a stone. Her diet was inadequate as she was a picky eater. There was no history of jaundice. However, there was, in addition, there is no abdominal distension or mass at the neck or inguinal region. There was no history of these symptoms such as fever, drenching night sweat, and loss of weight. There was also no history of familial blood disorder, history of chemotherapy or radiation exposure. Next. Other systemic review, basically this is the timeline of the HOPI. Next. Other systemic review, all the system is uneventful, but history, during the antenatal, the mother is reported to have anemia during pregnancy that resolved with medication, but no blood transfusion is needed. Prenatal and postnatal is uneventful. Nutritional history, breastfeeding, exclusively breastfed until 6 months old and started weaning afterward. Developmental history, the child's developmental is up to her age. Past medical and surgical history, her first hospitalization, this is her first hospitalization, doesn't undergo any operation before or any blood transfusion before. Drug history, not on any medication and no known drug or food allergy. Vaccination history, the caretaker reported that the vaccination is up to age with no other additional vaccine with no side effect. Family history, she is 2 out of 3 siblings. Sibling has no medical illness too. Father is a non-smoker with no medical illness, while mother is 28 years old, is currently well with no anemic symptom. No similar symptom in the family. Social history, they live near to the clinic of KK Maran, about 5 minutes drive. Currently, the patient was taken care by personal caretaker while the mother was taking care of the last born children. The total income for the family is 4,000 per month. On physical examination, the patient was alert and conscious, looked pale but not septic looking or sign of respiratory distress. Hydration status was mild. No dysmorphic feature or neurocutaneous sign. No cyanosis or jaundice. Her palms of hands and lips and sole of the feet were pale. Petechiae noted at the limb, back and the neck. Lymph node not palpable. No edema noted. The weight of the child is 10.5 gram and the height of 88 centimeter. However, I cannot trace the growth chart to say the growth is within what center and is it normal or not.
Why? Why cannot trace?
This was taken during, actually the patient was newly admitted. I clocked while the patient is newly admitted.
You clock the patient? Oh, ni you dapat daripada mana?
I dapat daripada year 3.
You dapat daripada student year 3 ke you sendiri?
Saya follow student to clock. Basically kita orang clock sama-sama.
Masa bila?
Year 3.
Masa
pediatric.
Masa you year 3 dulu? Masa year 3 dulu? Okay. You all year 5 kan? Okay. Alright. So why can't you plot? Kenapa tak boleh plot dekat growth chart?
Okay.
Boleh ke tak boleh plot sepatutnya?
Boleh plot. Boleh plot.
Patutnya boleh plot kan? Tak ada reason tak boleh plot kan? Okay.
The vital signs, the blood pressure was normotensive. Pulse rate was 120 beats per minute, regular rhythm with good volume. Respiratory rate 39 breaths per minute, tachypneic, and temperature was 37.4 febrile. GIT system examination, there is presence of hepatosplenomegaly. Other than that, there's no other finding in GIT. Summary, this is a 2 years, 9 months old girl with no non-medical illness, presented with postprandial vomiting for 1 day and associated with anemic symptoms, easy bruising and history of infection. On physical examination, the patient has a pallor, hydration status was mild, pedicure at the limbs, back and neck was noted. She was also tachypneic and there is presence of hepatosplenomegaly.
Stop. Okay. Alright. Fine. Let's go to your colleagues. Kita ada berapa orang ni? 18. Ramailah pula. Stop sharing. Okay, so what we'll do is we'll go to your colleagues sorang, and then tell us what do you think is the diagnosis, what is the provisional diagnosis, and what are the differential diagnosis. tell us why you think this is the provisional diagnosis, and why and when you tell the differential diagnosis, tell us why is this your differential and why is it not. What are the positive and negatives of all the differential diagnosis? And then comment on her presentation as well. What do you think? If you think it's good, why you think it's good? If you think there are other questions that you want to know, you can ask. If you think there's other way that the presenter should have improved, then tell us as well. Okay, all right. Okay, I'll go from my screen. Yang first will be Izzah Ibrahim, lepas tu Anis Arisha, lepas tu Zahra Najwa, lepas tu Fatin Alia. Lepas Fatin will be Wan Nur Syami, tu saya nampak nama, tak nampak nama penuh. And then Wan Nur Syamimi, and then Fatul Hakim, and then Farahiza, Zain Samsir, Nur Hazikah, Syahirah Kamal, Ali Gamon, siapa ni? Hafifi, lepas tu Azlan Izwan, Hassan Nasri, Aisyah Sojak, and last sekali Nur Alia Zahari. Okay, alright, fine. Izzah, diagnosis. Tak dengar Izzah, tak dengar.
Okay, my provisional diagnosis would be acute lymphoblastic leukemia.
Why?
Because it affect all the white blood cell. There are symptoms of anemia, easy bruising. Infection tak ada kan? Ada previous infection lah.
So why ALS?
Because the age of 2 years old is peak incident for ALL. And ALL also the most common malignancy in children. Okay.
You know the patient already, is it? You kelas sekali dengan patient ni? You kelas sekali dengan orang?
Tak.
Okay, alright, fine. Okay, lagi?
My differential. I'm not sure about differential.
Can't think of any differential.
Iron deficiency anemia. Because the symptom of anemia tadi, and then history of picky eater, and then Pica. Okay, next comment.
Okay.
Can I proceed with comment?
Nah, cepat.
Okay, for comment, actually I can't really follow the presentation lah, but it's good that she tried to cover every aspect, every system. But for example, because the chief complaint is vomiting, but I can see that she tried to rule out increased intracranial pressure. But other differential diagnosis of vomiting is not seen to be tried to rule out lah. Two, about the easy bruising also not specify why it said that is easy bruising, because about the history of fall is the bleeding resolves spontaneously.
Okay.
Okay.
I expect 5 differential diagnoses. I expect from year 5, you should have told me at least 5 differential diagnoses. So as doctors, when you see any patient, among the most important thing you need to do is actually give the differential diagnosis. Because without proper, adequate differential diagnosis, you don't know what are the questions you need to ask. You don't know what are the important things for you to do when you examine the patient, because it's not possible for you to do 100% full examination. It's not possible. So the only way how you can do proper physical examination is when you have good differential diagnosis. You can only ask appropriate questions when you know the differential diagnosis. So having good differential diagnosis is very, 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 very important. So I expect for fifth year, so for fifth year you should have at least 5 differential diagnosis. So what we are doing now, if you have later on, bila you dah balik face to face pun, if you have teachings with me, long case, it will always be like this. One person present, and what I want from you all is your colleagues should give what is your provisional diagnosis and why do you think that this is your provisional diagnosis? What are your differential diagnosis? Why and why not? Why? Because few things. Because this assess the presenter and also assess the listener as well. Kan? If the presenter present history very good, very clear, targeted, kan? All your colleagues from the same level of knowledge, the same level of clinical acumen, same level of clinical judgment, should understand, should faham you are where you are going with your presentation. Kan? Where is your apa hala tuju ni pergi ke mana? Kan? Your colleague should have among the same different provisional diagnosis. Kan? Kalau your colleague semua pening kepala, scratch your head, apa provisional tak clear, mungkin hala tuju tak apa tahu ke mana nak tuju. So your presentation is not clear enough, it's not targeted enough to the provisional diagnosis. Kan? Sama juga dengan differential diagnosis. If your colleague semua pening kepala tak tahu what is the differential diagnosis, probably it shows your history, your presentation is not robust enough. It does not cover adequate differential diagnosis. Kan? Sebab kalau your colleague yang same level as you, bila dia dengar, they should tahu dah, okay, you are trying to rule out this, you are trying to rule out this. And it shows the level of your presentation. It also assess the listener as well. Kalau listener tu tak reti, tak tahu apa provisional, probably the problem is not the presentation. Probably the problem is the listener, tak reti apa benda. Sama juga your listener tak reti apa, tak tahu differential. Kan? Despite presenter has already presented really well. So it assess both. Kan? It assess juga your both in terms of, because we can only improve kalau kita tahu what are our strength and what are our weaknesses. Baru kita boleh improve. Kita tahu which component of our presentation that is good, kita boleh improve on that, build on that. Kita tahu which one is weak, dan kita boleh improve. Dia assess juga bukan setakat presenter, it assess you all juga. Kan? Kalau semua presentation tu teruk tapi listener semua kata oh cemerlang, terbaik semua. So probably you all don't even know what is the idea how a good presentation should be. So I'm assessing both. Okay, alright. Next, Anis Arisha.
Yes. Okay. So from the history, we can see that the patient has anemia, thrombocytopenia, and also neutropenia. So from the diagnosis, I want to rule out the cause of the pancytopenia. So,
Sorry. Again. Repeat. What did you say?
From history, it seems that this patient might have pancytopenia because the patient has anemia, thrombocytopenia.
How do you know the patient has thrombocytopenia?
Oh, differential. Okay, so with differential,
No. I'm not. We're still at your provisional. How do you know patient ada thrombocytopenia?
History, patient has easy bruising.
So easy bruising sama dengan thrombocytopenia?
No. 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 Okay.
Of course no.
No.
So pancytopenia baru dua cell line. Apa third cell line?
Neutropenia.
So how do you know patient has neutropenia? Do you know patient ada neutropenia?
History, the patient has history of infection, but it does not describe what kind of infection, how long. Okay. I need to change diagnosis. Okay. So
So first, I want to know the cause of the failure. So my different diagnosis is vitamin B12 deficiency, because the patient has failure, and also the patient is picky eater. However, the presenter does not describe what kind of the patient does not eat. The food that the patient not eat. And also, okay. Okay. So, and also another differential diagnosis is iron deficiency anemia, because the patient also picky eater. However, I still want to know the cause of the cause of FDAs, such as, is there the patient is wearing slippers during walking, because I want to rule out the worm infestation. Also, I want to know, does the patient has history of the chronic blood loss, for example, hematochezia, epistaxis. Next, I want to also, does the patient and also another different diagnosis is thalassemia, because the patient also has failure. Has prolonged failure. However, from the history, there is no family history that has a similar symptom. Okay, and also I want to add some history to rule out thalassemia, such as, is there any history of transfusion, on history of thalassemia among family members. Okay. Next, another history, another diagnosis is malignancy. For example, acute lymphoblastic leukemia, because the children has prolonged failure. Okay. Okay. However, from the history, the presenter told us that the patient has easy bruising. However, it does not well describe does the bruising occur spontaneously, and also, is there any mucosal bleeding such as epistaxis, gum bleeding, and also, is there any recurrent infection, because the patient only to history of the infection, and it does not well describe what kind of infection, how long it does occur.
Okay, fine. Comment.
Okay, so my comment is, the presenter needs to describe more about the presentation. For example, for the failure, for the failure is usually related with anemia. So the presenter need to tell us, is that the patient has any symptom of anemia, such as palpitation, reduced effect tolerance, shortness of breath. Okay.
Alright, fine. Next, Zahra Najwa.
Okay, so for my provisional diagnosis, based on the history and physical examination, since patient has prolonged failure and hepatosplenomegaly, so I would like to suggest acute leukemia. So moving on for my differential diagnosis, because of the hepatosplenomegaly and prolonged failure, prolonged anemia, I would like to suggest like thalassemia, and then chronic infection such as tuberculosis. And then
What's the presenter?
Yeah.
What's the splenomegaly, hepatosplenomegaly bersama mana?
Sekejap ya.
Presenter pun tak ingat dah.
Tak ingat. Okay.
Did you say just now hepatosplenomegaly?
Yeah, on palpation, the abdomen was soft and the liver was palpable with liver span of 5 cm and 2 cm below the costal margin. The spleen was
Liver
palpable.
5 cm.
5 cm and 2 cm below the costal margin. Liver span is 5 cm and then 2 cm below the costal margin.
Liver span 5 cm. How many centimeter below subcostal margin?
2 cm.
2 cm. So liver dia 2 cm lah. Okay, 5 cm ni is liver span. Spleen?
Spleen palpable measuring 3 cm from the left costal margin.
Okay, alright, fine. Okay, Zahra, continue. Sorry.
Malaria infection. Okay, and then because of there is some history of easy bruising, so I would like to suggest immune thrombocytopenic purpura, even though hepatosplenomegaly against that. And lastly, because of the acute vomiting, it could be AGE, acute gastroenteritis, or maybe dengue infection.
Okay.
So that's all my differential.
Comment.
Okay, so for comment, sorry Zen, it's a bit incomplete because first in terms of the history for the vomiting, you did not rule out any acute infections such as dengue or maybe any related to vomiting like leptospirosis, and then traveling history that could lead patient have malaria. Then for the failure, I would like to know more. This patient had prolonged failure, so did the parents seek any treatment or anything that parents did? Okay. And then any active bleeding, so you did not mention about it. And then for the easy bruising, yes, I agree with Anis Arisha. It's a bit, it's not detailed and it's a bit sudden, not very clear about it. And then, yeah, pretty much it's quite okay, but it could be complete more. So that's all.
Okay, all right. Next, Fatin Alia.
Okay, hello. So
Yes.
my provisional diagnosis for this patient would be beta thalassemia because patient presented with chronic anemia and also patient presented with hepatosplenomegaly. However, this is against my provisional because the presenter did not mention anything about thalassaemic phases in this patient, and also she did not mention any history of blood transfusion or family history of thalassemia runs in the family. My differential will be iron deficiency anemia because patient is a picky eater, and also she has a history of anemia. Okay. However, okay. My other differential will be intestinal obstruction due to worm infestation such as ringworm, because patient presented has lethargy. Also, patient has a vomiting for 1 day duration can be due to IO. However, the points against this differential will be patient did not presented with any no complaint of constipation or any abdominal pain. Okay, my other differential will be due to malignancy such as acute leukemia because patient is anemic, and also it has easy bruising. However, it needs more investigation about that, and also have history of infection. And my last differential will be acute gastroenteritis because patient presented with vomiting for 1 day duration.
Okay, comment.
Doctor, could I tell? I did mention that in the family history there are no blood disorder history, and also this is the first time admission and no transfusion history before.
Okay, all right. Comment.
So my comment for the presentation, so the chief complaint is actually quite clear that patient presented with vomiting. However, I think that the chief complaint should be macam mana? It's a specific with one complaint only. Like patient come for vomiting or lethargy actually, and then
Again. So you want the chief complaint to be only one?
ada macam the main reason why patient come to the clinic tu dia macam clinic HTAA is not like, is it because of vomiting or is it because of lethargy actually?
That's not right lah. That's not right.
Oh,
You
okay.
shouldn't do that. So chief complaint. Okay. One thing I need to remind you all. Chief complaint does not necessarily mean the actual problem yang patient datang to hospital. For example, if you have a child, if you have a child with febrile seizure, what is usually the chief complaint? What actually brings the child to the hospital?
Season.
Seizure.
Seizure.
So many students will say, okay, I'm presenting a case of 6-year-old Malay boy presenting with seizure for 1 day prior to admission. Lepas tu they start with telling all about the seizure semua. Dah habis cerita pasal seizure, baru patah balik. Okay, actually patient has been having fever since yesterday. Okay, can you imagine yang tu, you compare kan, kalau you kata, I'm presenting a 6-year-old Malay boy, known case of, had history of febrile seizure, had family history of febrile seizure, currently presenting with fever for 2 days prior to admission and seizure on day of admission. So by chief complaint dia, you dah tahu dah what is the diagnosis and where the presentation is going. Despite the actual problem yang mother dia bawa ke hospital is actually the seizure. Kalau tak ada seizure tu, with just fever, memang takkan sampai hospital pun. So sometimes, chief complaint, you need to modify the chief complaint based on your assessment, not just exactly the words from the caretaker, from the parent. Whatever mother says is always important, but that may not be significant. Significance, you determine what is significant. You determine what you want to put on the chief complaint. You determine what you need to put on the HOPI. You determine what you want to put in systemic review. So it's up to you. You assess based on what is important that is targeted towards your diagnosis. Okay. Because sometimes you need to put things, you need to put certain things dekat dia punya introduction pun. If you're presenting case of asthma, kan, you need to put 6-year-old Malay boy, known case of bronchial asthma, under treatment, under follow-up dekat mana, complying to treatment or not, dalam introduction. Lepas tu baru chief complaint. Kan? Tapi kalau dia known case of asthma, tapi datang sebab AGE, tak payah letak kat chief complaint. Lower down lah, dekat pas medical lah. Tapi if it's related, so you determine what is important dekat introduction. Okay, alright. Fine. Lagi, Fatin.
I think most of it already mentioned before, like bruising should be specified, like signs of easy bruising, gum bleeding, epistaxis. And also I already mentioned just now that to rule out thalassemia, we need to include thalassaemic phases in the physical examination.
I'm sorry, I did say that there is no dysmorphic feature while doing physical examination.
Tak boleh macam tu. That's too general. That's okay. You mentioned there's no dysmorphic features, okay, that's one thing. Tapi for certain diseases, you need to have clear description. So banyak, okay, even just no thalassaemic phases pun not adequate. You need to say properly lah. There's no frontal bossing. Apa benda yang you nak tengok. You need to specify. Medical students do not do shortcuts. You tak boleh you bagi satu benda, you throw something, you assume everyone clear. No, tak boleh. You kena specify kan. What
So
do you mean by
basically,
this?
memang kena list out kan.
Yes, of course. Shortcuts
Alright.
are for consultants. Jadi consultant nanti boleh shortcuts. Masa medical student, do not ever do shortcuts.
Okay.
Okay, alright. Next. Apa ni tadi ni? Tak ingat ni. The only siapa nama? Allah, tak lupa nama ni. Tak keluar pula nama kat my list ni. Sekejap Fatul Hakim, yes. Lepas Fatul, Farah Hizal.
Okay. So my provisional diagnosis is acute lymphoblastic leukemia. Because the patient is 2 years old and ALL is common among the children. My differential diagnosis is IDA because the patient is picky eater, and maybe because this patient is undergo like maybe have chronic blood loss or in growth, so increase in iron demand. And other thing is vitamin B12. Okay, and other than that, I would like to suggest beta thalassemia, but it's already um, clearly state that this patient had no family history of thalassemia, hematological disorder, or not receive any blood transfusion.
So kalau no family history cannot be thalassemia.
It can be
Kalau no family history of kalau no history of transfusion cannot be thalassemia.
it can be thalassemia. So that's
So?
why I put it as one of my differential diagnosis. So I would like to investigate the beta thalassemia also. And then for gastrointestinal system, I would like to suggest AGE because this patient have vomiting, and I saw that the presenter ruled out about no similar symptom in the family, or there is no history of eating outside. So maybe the presenter want to suggest that he want to roll out AGE for this patient. And then for neurological, I would like to suggest meningitis because this patient might have increase in intracranial pressure, but the patient did not mention, or I missed, but the presenter did not mention about any fever or photophobia or any neck stiffness. Okay, so that's all for my DDS.
Okay, comment.
So for the presenter, I think you should be more specified in detail about such as the picking the diet, the nutrition history, because you might say it, but we didn't know what did you ask. The first thing, and then
Okay, Abida.
beda.
Okay, Farahiza, next. Your turn.
Okay, so basically, my first differential would be
Provisional, what's a provisional?
okay, provisional would be meningitis. Point 4 because the vomiting episode that happened, and there is a previous history of infection. However, I do not know what kind of infection have been affected the patient had, and also because even though there is no history of seizure, but there's were no stated there's any history of neurological symptom or neurological signs. So that's one thing, the first provisional that we like to rule out. The second will be for I would like to put for uh, acute gastroenteritis. Point 4 will be the vomiting episode, but the vomiting episode, and also because because value. But point against, it will be because the patient also presented with bruises and hepatosplenomegaly, so it's less likely the failure is due to bleeding or due to bleeding gastrointestinal. The third differential will be thalassemia because it is a common point four. It is a common diagnosis for children who presented uh, with anemic sign and symptom, including hepatosplenomegaly. Same like my friend, point against there is less history on regarding the patient has any sign of thalassemic cases. And also the fourth one, eh, tidak bagi apa. The fourth one will be uh, leukemia. The point four sama lah failure bruising and hepatosplenomegaly and but I want to know more regarding the constitutional symptoms, for example like loss of weight, loss of appetite, um, um point against leukemia, it is stated there is no history of malignancy in the family and there is no sign of this adenopathy. Fifth, 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 the fifth question will be I want to put IBD, inflammatory bowel disease, because of uh, the 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 main focus is the vomiting episode. So probably there is a problem in the gastrointestinal. So and point four for the failure it can be there's a bleeding also from the GI. But however, point against, there's no history of abdominal pain because saya tak perasan ada history tentang abdominal pain ke tak. So that's together my comment lah. The comment is same like my friend. More history on the anemic and also the bleeding symptom, especially during birth. The mother had anemia during pregnancy, so I would probably want to know more on whether it's due to PPH ke ataupun there's a complication during the birth or there's any maternal infection ke which is can cause and also rule out more on the hepatic disease because I do notice there's because regarding anemia aside we want to focus on the possibility of thalassemia and also leukemia. I think we should also rule out the possibility of hepatic disease. Even though you already mentioned there is no jaundice, but we can further into that issue.
Okay.
I think that's all.
All right. Fine. Next, Azlan.
Yes, saya doktor.
Yes.
Okay, my provisional diagnosis will be acute leukemia because of the presentation of history of easy bruising. And then I will other differential is IDA. And then because of the failure, and then vitamin B12 deficiency because of history of picky eater. And then because the child because this pediatric, so thalassemia is important differential.
Actually, next time, if you tell about differential, you need to tell why and why not. So differential this because of this, but unlikely because of this. So that's how you go about telling differentials.
Okay.
Okay.
Yeah. Okay. Others would be I would like to rule out infectious such as AGE, but the history I think less. So the infectious, for example, AGE because of presentation of vomiting. So infection is important, and then however, there is no history of abdominal pain, and then history of travel eating outside. Okay. Meningitis is also differential because presented with ICP increase in ICP symptom, vomiting. However, there is no history of not mentioned like neck stiffness. Okay, okay, and headaches. For my comments, I think the same with others. Should be thorough. We need to really ask about the symptom first. I think because maybe because the kurang differential code at the time. So yeah. So mungkin kita improve lagi untuk increase to broad the differential. Okay.
Okay. Alright. Next, Anis Arisha.
Dah doktor tadi.
Oh, dah tadi. Okay. Wan Nur Syamimi.
Dah.
Hah? Wan Nur Syamimi dah ke? Belum kan?
Belum. So my provisional diagnosis, I was thinking of leukemia because this patient, first of all, it is young, 2 years 9 months old, around 3 years old, and the patient has pallor, also has presented with easy bruising, and on physical examination, this patient has hepatosplenomegaly, which is likely to be acute lymphoblastic leukemia. However, this patient has no any family history of malignancy, and on physical examination, there is no lymphadenopathy, which can be sign of leukemia. My differential diagnosis would be iron deficiency anemia, as this patient has pallor, lethargy, and he also is a picky eater. However, there is hepatosplenomegaly, which is against iron deficiency anemia. Next differential would be vitamin B12 deficiency, as from the history, we know that this patient is a picky eater. Another one could be thalassemia. Also, the patient come with pallor and has history of infection and hepatosplenomegaly. However, the patient has no jaundice, no family history of any family with thalassemia, and no history of blood transfusion. And last but not least, AGE. So because the patient presented with vomiting, however, there is no history of eating outside, there is no similar symptom in the family to suggest acute gastroenteritis. So I think that's for diagnosis. For the comment, as mentioned by friends before, so need to thorough more on the history of presenting illness, such as for the vomiting. So we know that this patient presented with vomiting, but you need to rule out any other acute causes, acute infection, like is patient presented with fever, any travelling history, any this patient come from dengue prone area or not. And this patient presented with lethargy for like 5 weeks, which is more than 1 month. So what actually the mother do? As the mother noticed, this patient has become lethargy more than 1 month. So what actually the mother do? So does the lethargy associated with any, does the patient is sick with associated with the lethargy, like the patient has fever, because 1 month is very long. And regarding the easy bruising also, is it spontaneous or is it due to trauma? So need to describe more about that. So I think that's all.
Okay. We don't have that much time because ideally we need to stop around 5 lah, kalau tak problem. Okay, let's go back to the presenter.
Yes,
Presenter. What is your provisional and what are your differentials? Sudah hilang presenter. My Sarah.
Sorry.
Nah.
My provisional diagnosis is acute lymphoblastic leukemia complicated with central nervous system involvement. Since the points for the age is children, there's a history of vomiting that can indicate CNS involvement, and since CNS involvement is particularly common in ALL, and then failure.
Not that common lah. Possible but not that common lah.
Failure, lethargy, and then there's presence of easy bruising, history of infection, unable to sleep due to generalized body pain that might indicate bone pain, and then hepatosplenomegaly. Points against, there's no convulsion, seizure or irritability to strengthen the CNS involvement, and then there is no skin involvement such as nodules. Differential diagnosis, I will go for lymphoma. Points for, there's presence of vomiting, pallor, lethargy, easy bruising, history of infection, hepatosplenomegaly, and unable to sleep due to generalized body pain. Points against, there's no B symptoms such as fever and night sweat. No lymphadenopathy. And then AGE, number 3 is AGE. There's presence of vomit, pallor and lethargy. Points against is no fever, no diarrhea, no history of eating outside food, and no similar history within the family. Number 4 is iron deficiency due to the picky eater. The same description that all my colleague members say. And then the last one is maybe acute myeloid leukemia, although it is not that common in children. Presentation is the same: vomit, pallor, lethargy, easy bruising, history of infection, unable to sleep due to generalized body pain and hepatosplenomegaly. Points against is young and no CNS involvement. That's all.
Okay. I don't think we have time to go through more detail. But okay, let me comment a few things. I'm not entirely happy with the presentation actually. The thing is, okay, few things. When you present something, I think your chief complaint though, it's not good enough lah. Your chief complaint is not good enough. When you started the history tu, dia tak berapa clear where you're going. Is it related or not? Is the vomiting related to the 5 weeks complaint of lethargy? Your chief complaint lethargy je. Dan kan pallor should be important lah kan. So is it just lethargy or is it pallor and lethargy? Bila dah masuk HOPI baru you mention about pallor.
Doktor, nak confirmkan in the chief complaint, we can put how many chief complaint? Is there any limited? Or
what do you think is important? What do you think is the most important? What do you think is the most important?
Alright, okay.
So it's up to you. You determine, kan?
Alright.
So so what is the most striking complaint that the child has? Kan? So and then bila you present pula, okay fine, you nak start on one day, you start on the acute. Okay, so this is a chronic problem, 5 weeks. Acute event is the vomiting. Tapi bila vomiting tu, okay, I saw you trying to roll out increase ICT, SOL by saying non-projectile, blah blah blah. Tapi it's not that enough. You kena go detail lagi. Apa vomiting dia food particle ke tak, can they still tolerate orally ke tak, the whole day tu tak boleh makan langsung ke, atau atau ada sikit boleh makan, ada cough tak, is it you mention postprandial after meal, ada cough tak, apa ada blood tak, apa nama diarrhea, apa lagi ada abdominal pain tak, apa lagi maknanya you
basically the system lah.
Everything, because and then vomiting, you know, one of the most important complication of vomiting is dehydration. Is there any signs of dehydration? Have you looked for other causes for vomiting? Even though the child has leukemia pun, what is the cause of vomiting? Is it just because of CNS involvement, or is it because of something else? Is it because of AGE? Is it because of gastritis? Is it because of whatever? Is it because of migraine? Is it because of apa? Is it something other infection? Is it sore throat? Some sore throat can cause vomiting as well. So is that sore throat? Kan? Pharyngitis. So you need to look for the cause of the vomiting. Is it because of ophthalm? Kan? Because certain eye condition can cause vomiting as well. And so you need to go through the history. What is the cause for the vomiting? So if you think it's related, then you need to make sure that the way you present, everything is tied up together. Easy bruising. So and then you mentioned about lethargic. So you mentioned lethargic for 5 weeks. Okay, no, sebelum tu dehydration, vomiting ni problem dia is complication, is dehydration. Bila you present acute phase ni, you kena present what happens in acute phase lah. Vomiting mak dia buat apa? Mak dia bagi minum ke apa betul ke? And then what's the condition of the patient at admission? Conscious tak, alert tak, what was done? Now you nak make sure that you have ruled out, you have at least go through the dehydration bit. Macam mana condition dia? Urine output dia okay tak? Reduce urine output ke tak? BO frequency dia macam mana? Kan? And then you mentioned about lethargic. You start going back towards the history and lethargic for 5 weeks ni. Okay. Fine, lethargic is one thing, tapi lethargic dia ada banyak lagi benda. You nak kena tengok, dia lethargic ni is because of apa? Lethargic ni, is it because of because of anemia? Or is it lethargic because of something else? Is it lethargic because of nutritional issue? Kan? Is it lethargic because of some underlying chronic illness? Is it lethargic because of brain punya problem, brain tumor? Is it lethargic because of renal problem?
Okay, I'm sorry, doctor, about the lack of information because I clocked from the.
It's okay. It's okay. I'm trying to teach you all how to what are important information you should have mentioned. Okay, so bila you mention about lethargy, you need to go through all other history that is important for you to diagnose what is the cause of the lethargy. Fellow pun sama. You need your history. You should go through all the causes. That's what I say. Differential diagnosis is very important. So what are the differential diagnosis of fellow? Because your differential, dia ada 3 yang lebih kurang sama. Acute lymphoblastic, acute myeloid leukemia, lymphoma. These are blood malignancy. I will put them on the same group. Faham tak? So maknanya you mesti ada 2 lagi differential diagnosis yang lain. So if you think about IDA for example, then you need to explain IDA kenapa pula ada vomiting. Probably IDA, unlike IDA ada ataupun thalassemia, but ada satu acute infection. Probably kan, kalau dia thalassemia trait for example, sometimes ataupun dia mild type of thalassemia, sometimes a new infection can trigger kan, ataupun dia ada hemolysis punya issue. Infection can trigger something. So but this 5 weeks you need to go through what are the other problems with PENLAW ni. And remember, PENLAW has complication. Apa complication dia? Among them is cardiac issue, cardiac failure. Ada symptoms of failure ke tak?
Okay.
Or is failure the cause for the lethargy?
Okay.
So you need to go through all those history. Easy bruising. Fine. Easy bruising lagi. What type of easy bruising? Macam mana jadi easy bruising? What do you mean by easy bruising? Where is the bruise? How big? Kan? Lepas tu you need to, what are you trying to say? Are you trying to point toward a platelet issue or coagulation issue? Sebab platelet issue biasanya ada PTK. So where are you going to? Maknanya is there element of sebab chronic problem 5 weeks parent tak buat apa-apa, could it be actually non-accidental? Could it actually be neglect? So you need to go through all those history as well. Ada pika, sen, datang mak tak bagi makan, pasir dia di rumah kan? So you need to go through all those things. So dietary history is extremely important. This sort of patient, dietary history is extremely important. Okay, fine. And then you go through physical examination. So physical examination, one thing I would expect is, so this child is 10 kilo, 2 years, 9 months, almost 3 years, 10 kilo, 10.5 kilo.
Yeah.
Do you think this child is small?
Thinner. Small.
The child is small for 3 years old, 10 kilo, that is very small. That is very small for age. Kan? The child must, I assume the child should look thin lah. Kalau tak thin maknanya dia pendek. Kan?
Okay.
So, and then, so you need to, okay, satu, what's the body size? Does the child look obese or the child look very thin? The child look sick ke apa? What is the body appearance? Kan? And then you need to look for the, again, weight and height. I have mentioned before dalam lecture kita pasal growth and nutrition. I mentioned already. Medical student, I expect you need to mention the centile. Weight berapa centile, height berapa centile. If you don't have ini, you should be able to look at the growth chart online pun dah ada, kan? And then not just that, head circumference. Head circumference is important as well. Kenapa? This child is just 2 years old. Okay. Ada datang dengan vomiting. Obviously, you need to assess what the head circumference. Kan? Kadang-kadang dia punya fontanel dia buka lagi tak? 2 years, fontanel still open. Probably there's some underlying more significant illness. Kan? So you need to go through all those things. Liver span. Liver span has no use in pediatrics. Okay. Don't say liver span. I don't want to know liver span. What is the normal liver span? Is this liver span normal ke tak normal?
I tak tahu about liver span, tapi yang under the coastal tu more than 2 cm is
liver span is not important for children. Don't do because there's no normal value. There's no normal value. So how can you say this is normal or abnormal? Kan? So just look at the liver, how many centimeters below the subcostal margin. Spleen pun sama. But that's not enough. Bila you mention liver is palpable, 2 centimeter below subcostal margin. There's many other aspects to that. Is it pulsatile tak? Are you looking at heart failure? Is it pulsatile ke tak? Is that, how about the surface of the liver? Is it smooth surface or is it nodular? Are you looking at liver tumor? Kan? Is it tender? How about the edges? Is it sharp edge? Smooth surface tak? Is it all the liver besar ke just one lobe? Kan? Both lobes besar ke tak? Is it move with respiration? Kan? So you need to go through all those things. Spleen pun sama lah. Spleen tak apalah, you mention spleen, but definitely we will ask you how we know that this is spleen. Then you need to mention lah. Tapi you need to mention lah surface of the spleen tu macam mana.
Doktor, the normal, yang spleen saya tak tahu normal below coastal margin tu kira berapa dia punya normal range?
Normal range spleen should not be palpable lah.
Not palpable. Okay.
Even the throat space dull pun nampaknya spleen dah besar.
Okay.
Kan? So liver and spleen. So lymph node you mentioned. And then, okay, again, what are your differential diagnosis? So look back. Bila your differential diagnosis should determine what you should mention during your physical examination when you present physical examination. You are thinking of something anemia related, IDA, thalassemia. What are the findings? So you need to mention lah. Tak ada this particular finding. Even finding related to iron deficiency anemia, koilonychia for example. So those are things that you should mention. Anemia related dengan heart failure, kan? So you need to mention about proper cardiovascular finding. The one you presented just now, just abdomen, itu pun not detailed enough. And then other symptoms, other system are unremarkable, other system are normal. That is not acceptable. Why is not acceptable? Because you need to mention about cardiovascular. Cardiovascular need to be more detailed. Neurological should be more detailed. Because can this be a brain tumor? CNS tumor, can this be a CNS tumor? Definitely, you need to think of CNS tumor. So history pun tak cukup pada CNS tumor. Examination pun you need to mention about CNS tumor.
Alright.
Kan? So CNS, neurological examination, kena be more detail lah. Kena be more detail.
Alright.
So I expect from medical student, kan, you should always present full. Presentation, physical examination, you should always present full. There's only two situations where you do not present full. One is if you do not have time, your history is already too long, panjang sangat dah, tak sempat dah. Then you cut short. Okay, itu pun I don't accept you to say other system are normal. No, I don't accept that. Even then, I expect you to say respiratory system is normal, patient is not tachypneic, chest is clear, no added sound. Cardiovascular examination is normal, first and second ultrasound is heard, no murmur. So I do not accept semua sistem normal. Even if you say other system are normal, you need to go through respi apa, cardiovascular apa, because that tells us you know what you are presenting. You know what is the problem with the patient. Because if you say other system are normal, it tells us that you do not know. That will be our assumption. As examiners, that will be our assumption. You don't know what is important. You don't know what is significant. Okay. So never, as medical student, never kata semua normal. Even if you say normal, you expand a bit.
Alright.
That's the first situation yang you boleh shortcut sikit bila tak ada time. Second is when we explicitly tell you just present about this system. So there's only two situations where you go only one system, then the other you kata normal. Satu, when you do not have time. Second is when we explicitly tell you just present about this particular system. Kalau tak, always go through all the system. And you need to practice that. Kalau biasa shortcuts, then you'll be in trouble. Okay, alright. We really need to stop. Kalau nak, I think we can arrange another session for us to continue discussion. We can continue so many things lagi nak discuss about investigation, discuss how to approach. We can arrange. I think we need to arrange another session lah. You guys discuss bila you all are free, and then tell me, and then kita continue balik. Boleh? I really have to stop.
Boleh, doktor.
Malam-malam boleh.
Okay, doktor.
Okay, alright. I think let's end our session here. Let's end with tasbih kafarah. Assalamualaikum.